Hi, I'm Natalie Callander from the University of Wisconsin, and I am presenting at ASH the substudy from DREAM-5 that is entitled Investigating the Synergistic Effects of Belantamab Mafodotin plus Inducible T-Cell Co-Stimulator Agonist, or aICOS, combination therapy in patients with relapsed and refractory multiple myeloma. And I'm happy to do so on behalf of all of these investigators listed from around the world. So as many people may know, belantamab is a first-in-class monomethyl auristatin F containing B-cell maturation antigen-directed antibody-drug conjugate that's approved in the United States for patients with relapsed and refractory multiple myeloma. And it was approved on the basis of data from the DREAM-2 study that showed that there was an overall response rate of 32% in patients who were receiving IV 2.5 milligrams per kilogram of belantamab every 3 weeks. Now, one of the big points about belantamab is that it's a steroid-free regimen, one of the few in myeloma, which is important. Now, the response rate overall was only 32%, but of the patients who did respond, more than half of them had a very good partial response, meaning that they had very little detectable myeloma. And those responders actually had their response prolonged for 11 months and survival for 13.7 months. And this was in a very heavily pretreated group of patients. So since that study came out, it makes a lot of sense to combine belantamab with other anti-cancer agents, particularly those that may be thought to have had an immune effect. And so what I'm presenting is a sub-study that is looking at belantamab combined with a drug called feladilimab, which is an ICOS agonist. And let me tell you what that is. So this slide basically is showing you on the left the mechanisms of actions of belantamab. So primarily it is thought to bind to B-cell maturation antigen on a myeloma cell, and then the payload, which is this auristatin, comes into the cell, binds to tubulin and doesn't let that tubulin polymerize, and that means that the cell will eventually die. But there are other mechanisms that belantamab may be important, and those have to do with antibody-dependent cellular cytotoxicity and other immune effects, including phagocytosis. So it has, we think, a number of different actions when belantamab is administered. So ICOS is actually a member of a group of receptors called CD28, and it is expressed on T cells that are CD4 and CD8 positive. And it's thought to be very important in T cell proliferation and activation. And perhaps many of you know that what is called an exhausted T cell may be a characteristic of people who have very advanced myeloma. So this makes sense to take an agent that can help kind of wake up T cells and combine that with belantamab. So the DREAM-5 study is a really neat design because what it means is that you can take combinations with belantamab and test them in a very straightforward way in what we call dose exploration phases. And so because it's one protocol, that means that you don't need to keep opening protocol after protocol. You can just add in more combinations that look promising. And on the left here, there's some of the combinations that are undergoing testing. And I am presenting data on the feladilimab, which is the ICOS agonist. So if any of these combinations look promising in the dose exploration phase, they can then be brought into what's called a dose expansion phase, where they're tested against single agent belantamab to see if they really are superior. And those combinations that are can then be taken to a phase 3 trial for registration, and that may be for drug approval. So the study design is pretty straightforward, matches DREAM-2 fairly closely. Patients had to have at least 3 prior lines of therapy, including an IMiD drug like lenalidomide, a proteasome inhibitor like Velcade or carfilzomib, and an anti-CD38 antibody. They had to have a way to measure their myeloma. So they had to have either an M protein or some light chains or protein in the urine. They had to have good organ function, and they had to have what's called a performance status, that is how well you're getting along, of 0 to 1. You could have had a previous autologous transplant, but you could not have had an allogeneic transplant. And you could also have had previous B-cell maturation antigen-directed therapy in this dose exploration phase, but not belantamab. And there are a couple exclusions, like having treatment within 2 weeks of the first dose of study drug and a monoclonal antibody within a month of study drug. So the different cohorts are shown here. This is belantamab combined with the ICOS agonist at 8 milligrams a week, 8 milligrams a week with 2.5 milligrams per kilogram of belantamab, and finally the ICOS agonist at 24 milligrams per week. And these were flat dosed. The ICOS infusion takes about 30 minutes. And if you look at the people that are in this sub-study, there were 25. Their median age was 69. They were split evenly between men and women. 84% of the patients were white. Now, none of these patients had extramedullary disease, but we did not mandate a PET scan at the time the study began. The median prior lines of therapy was 5, and 17 out of 25 patients had more than 5 lines of therapy. We didn't have any patients who had extramedullary disease, meaning myeloma outside of the bones, but we didn't mandate a PET scan, so it's possible that some patients did, and about half of them had had a previous autologous stem cell transplant. So let's look first at the overall outcomes in terms of response rate, meaning at least a partial response. That occurred in 52% of patients, or 13 out of 25. And if you look at the patients who had a VGPR, that is a very good partial response or better, that was 32% of the entire group, or 57% of responders. If you look at the bottom line of this slide that's bolded, there was a suggestion as the dose of the ICOS agonist and the belantamab went up, there might have been better responses, but the confidence intervals are big, and this is obviously a very small sample size. But we thought the response rate was very favorable. Now let's talk a little bit about safety. So many of you may know that belantamab has been associated with a side effect called keratopathy that we're going to talk about in a minute, which stands for corneal irritation. About 96% of patients did have an adverse event, but only 3 patients actually dropped out of the study because of adverse events. And most of the adverse events were managed by either delaying doses of belantamab or decreasing the dose. And in terms of those adverse events that were thought to be directly related to study participation, those were 84% of the adverse events. Now, no patient died during this study because of adverse events, which is important. So belantamab, as I mentioned, has been associated with a side effect called keratopathy. And in this particular study, the overall rate of keratopathy was 60%, or actually 44%, excuse me. And in terms of grade 3 or 4 keratopathy, and that would be one that would really be symptomatic, that was only 20%. And although that level is high compared to DREAM2, that rate of keratopathy in that previous study was 74%. So this seemed to be somewhat better. There were some patients who had some dry eyes and some other side effects, but they tended to be mild. And in 2 other side effects that we were interested in looking at, one was infusion-related side effects, and that occurred in about 1/3 of patients, but those were very mild. And finally, low platelets or thrombocytopenia also occurred in about 1/4 of patients, but again, most of that was very mild. So in conclusion, it makes sense to combine belantamab with a number of other agents, particularly those that may have some immunomodulatory effect. And in the DREAM2 study, the overall response rate to belantamab was 32%. In this current study, combining belantamab with the ICOS agonist, the overall response rate was 52%, with 57% of those achieving at least a VGPR. There was 84% of patients developing an AE related to study treatment, but these were managed by dose delays and reductions, and there were no grade 5, there were no deaths on study. So this looks encouraging, and thank you.